right, so without further ado, we will speak with Dr. Mahmoud Traina, who will teach us about TAVR and cardiogenic shock and severe LV dysfunction. He's from Cleveland, Abu Dhabi.
This one. Thank you very much, Ahmed. So I have good news for you. I thought this was a 10-minute talk, so I'll save you some time.
No worries.
Okay. All right. I think I'll mostly present. Who's moving my slides? Somebody moving my slides? Okay. So I'll mostly present a case, and I think it then discuss some of the data on this. So this was a 36-year-old male with known congenital aortic stenosis. Kind of blew it off, lost the follow-up, and then he presented to an outside hospital with dyspnea, edema, nausea, and weight loss over the last month. So he came in, was found to have congestive hepatopathy, AKI, and severe pulmonary edema. Echo was done, showed an EF 10%, moderate to severe RV dysfunction, and critical, even with the EF of 10%, had critical aortic stenosis with a mean gradient of 56. So he was transferred for consideration of high-risk surgery plus or minus balloon valvuloplasty prior. So kind of here's the heart here. You can see, again, really bad LV function, really severe, typical kind of congenital bicuspid type valve, or unicuspid, what we used to call, with two raphes heavily calcified. Again, just some more images of the very bad LV function, and the RV a little bit dilated and function reduced. And you can again see here, by the time he got to us and he was on some pressors, his mean gradient was up to 75, even with this LV function. So on transfer, he was in shock. Lactate was 4.3. He was started on some dobutamine and norepinephrine, had shock liver. The enzymes were in the 2000s. T-billy was elevated, was in AKI with a creatinine of 170. He was placed on non-rebular face masks for oxygenation, had a bedside swan done in the ICU. PA pressures were in the 80s with a mean PA pressure of 60. Wedge was 45. Index was 1.7. We did an MDT bedside, surgeons and the interventional team. We said he's too high risk for AVR now, but given he's 36, let's try to medically optimize him, stabilize him, and just in case, let's obtain the TAVR CT. So this is the, oops. And this is the TAVR CT. Again, you can see some subvalvular calcium, so there's some LVOT calcium. Heavily calcified valve. I think the calcium score was in the 5,000-6,000 range, but good coronary height, good sizing. This is kind of our analysis that we do. Big annulus. So the second box is our the second box up here. This is the annulus of 700, perimeter of 99. Good size sinuses, good STJ, good coronary heights. And no peripheral disease, some LVOT calcium, but otherwise okay, and kind of plan what to do. So initially he started to improve on medical therapy with some dobutamine, norepinephrine, and the LFT started to get a little better, renal function started to get a little better, and then on day 3 started to crash. Of course, as these things tend to happen overnight. The pressure requirements began to worsen around midnight. We called a shock team, and ECMO was placed at 2 a.m., and then the plan was to take him at 6 a.m. To the hybrid OR for emergent valvuloplasty plus or minus TAVR. So in terms of the outcomes, this is TAVR and shock. This is kind of my main slide in terms of the outcomes. Patients have about a 10 to 12% in-hospital mortality. With about a 30% one-year mortality. And if you adjust it to landmark, actually if the patients survive the initial procedure with TAVR, their actual outcomes are relatively similar to patients that didn't have shock. Now this is all-comer shock. I tried to find, and I went through the literature, and I'll show you a couple more slides, is there any differentiation on patients that are on mechanical support or not? So most of these patients, of course, are on just pressor support, so vasopressor support. But patients, obviously, the more they're on dialysis, the patients that have worse, of course, if they're in shock, they're usually class 3 or 4, are less likely to survive, and the patients that had a prior ICD, meaning they already had a cardiomyopathy, are also less likely to survive. So those were the biggest predictors of poor survival. So the mortality is about 3 to 4-fold higher than in the acute phase than in patients without shock. So we took this patient. It was challenging across because you can imagine the patient had a mean gradient of 60 with AEF 10% and now has ECMO closing that valve completely. So it took us a while to cross. I don't know why my slides are auto moving. Okay. But eventually was able to cross, and then we did the BAV with I think this was a 23 balloon, if I recall. It kind of slipped around a bit, a 25, sorry. We eventually got it with a 25 balloon, but then post, again, as you would expect with ECMO, and kind of we had a high likelihood this was not going to be enough. He had severe AI, and that's clearly shown here by the hemodynamics as well. The gradient didn't improve too much, and you can see the LV and diastolic pressures shot up, and there was severe AI, so kind of had no choice but to put in a valve. And this is kind of the echo images here. And severe AI post balloon valvuloplasty. So he put in a Sapien 23 valve. Pretty standard deployment. No residual AI. This is with the ECMO in place. And hemodynamics, I mean, this is one of the more dramatic cases I've seen. So again, because he's young, so immediately the LVDP went down from 45 to 22. And we were not planning on this. The echo post-procedure looked great, but we were not planning on this initially. But we decided to cannulate immediately on the table. So we cannulated the ECMO, same time. Pressors were weaned off by the evening, and then within 4 days, heart failure was fully compensated, and LFTs normalized, renal function normalized, and patient was discharged on day 5. 1-year visit, he was asymptomatic. I think this is now, his 2-year visit was a few months ago. He was really doing great and back to normal activity. And his echo 2 months, LV completely normalized. So all that LV dysfunction, as we expect with AS, was all related to the aortic stenosis and completely normalized LV function. So, as we go along, this is becoming more of something we deal with. The more you can do, the lower the risk starts to become, the more people ask you to do crazy stuff. And you kind of, the numbers are increasing. So TAVR for cardiogenic shock is increasing. The mortality in this kind of registry trial was about, again, 12%, similar to the previous. And this is across multiple groups and multiple studies. And it's in that 10 to 15% range in general. And obviously, if they require mechanical support, is higher. If we look at predictors, main issues, most things are relatively similar between the shock and no shock. But of course, vascular complications, because a lot of these are done with small vessels, more urgent cases, are much higher in the shock group. So in terms of my personal experience, we've done 12 cases of TAVR and cardiogenic shock, 4 of them on ECMO, 3 on balloon pump, 5 patients on vasopressors. You start to do some of these and the patients do well, so then you start to do more. And then kind of willing to take on more cases. Our most recent case was actually just very recently. Our only mortality in this group, 68-year-old was transferred with cardiac arrest, actually en route, and then had an emergent ECMO placed. And then that night we did an immediate TAVR using TE sizing. So as like with these kind of cases, so actually hemodynamics improved, but then he developed complications of mechanical circulatory support. So, the TAVR is one part of the equation, as we know with the mechanical circulatory support, ECMO, balloon pump, Impella, all of the above. You get issues with thrombocytopenia and GI bleed and sepsis, and so he eventually passed away just a couple weeks ago. So it's a challenging issue, and I think this is kind of, I'll just give you my take-home messages and my personal perspective, and I'm curious what the rest of the panel thinks on these things. As TAVR becomes safer and has become safer, we're asked to do higher and higher risk patients and more acute patients. I'm sure all of you get those patients that refuse when they're well, and then they come in acute pulmonary edema, heart failure, shock, and then you're kind of making decisions on what to do. I think decision-making in these patients is challenging when you have a severe AS and a shock in the hospital. it's very critical to understand the reason for decompensation. I think, is it sepsis? Is it a GI bleed? Is it, what triggered them? Or is it just the progression of the disease? I'm going to give my personal perspective here, so it's not data, but I think valvuloplasty is going away mostly. I don't like it personally. I don't think it works very well and often gives people AI. And I think the real reason, at least in our practice, that we're doing, you're taking on the risk of the procedure without the full benefit. So the main reason I use it is in the setting of sepsis and bacteremia, so where I don't want to put in a prosthetic material. But if I'm going to go ahead and treat the valve, treat it fully usually, and kind of go with a TAVR, do it early in the course of a shock patient unless there's a reason to wait, and then kind of get the valve in because they tend to just progress and get worse. Thank you.
Join us, please. Great cases, very nice, and this guy was impressive for sure. I think, like from my perspective, I've done a few cases like this, less than 10 for sure. And like, how much of this is, how much of the LV dysfunction is attributed to the valve, and how much there is coronary artery disease? If it's only the valve in question, there is a very high chance the patient will recover. If there is coronary artery disease, it's a done deal, and like in my very humble opinion, like I would see the patient almost will never recover because it's the coronary artery disease. Which, with that, if any,
I just have a comment here. So it's a great case, Mahmoud. I mean, it's a great save. But a young patient with such a rock sitting in his LVOT, generating mean gradient of 56, good reserve despite that. Liver dysfunction and kidney impairment, I do think he would have done well with the operation. I don't see Fahad in the room, but maybe another surgeon can reiterate what I say. Probably.
So, question.
I would have operated on that patient.
Question though, even with an RV dysfunction, severe RV dysfunction, you're happy to take the patient
If it's AR, I will not operate, but AS, these patients usually, if you do quick in and out operation through sternotomy, short bypass time, good protection, they do fly off the operation.
Won't be as quick as TAVI.
It is funny enough, actually. I operated on the same age, 36-year-old. Came to hospital, severe AS2ER, admitted overnight, arrested, and moved to medical ICU. They resuscitated. I saw him in the morning, intubated, very severe aortic stenosis, and cardiogenic shock, liver failure, renal failure, and so forth. Taken immediately to OR, and he did well. And the message, I think I totally agree with the last point of his message. Severe aortic stenosis and cardiogenic shock, don't think about it, don't delay it, and bite the bullet and take it to OR.
So two surgeons agree.
So actually the good thing about this case is the mean gradient is like in 70. So that tells you that the ventricle is still strong enough to tolerate what happens after you open up quickly the aortic valve. But the issue is if you have like a gradient of 20 burnout LV ventricle, this is where the high risk comes in.
Well, I guess the actual gradient is higher than 70 in a patient with severe LV dysfunction. Congratulations on managing that very challenging, critically ill patient. My question to Dr. Abdurrahman, so this patient is going to come back in 7 years' time, 10 years' time, by best, with degeneration of his transcatheter valve. What would be the options at that time?
He's still young, so he's 36 years old. So, of course, I would discuss it in the heart team meeting and see the opinion of the surgeon, whether could they do anything for it in terms of surgery. I know that taking out this valve after many years is not an easy, but I mean, it's a case by case. Of course, there is an option for valve and valve.
I do think, it's a Sabian valve. I don't think we'll know about it, but having that calcium around it, I don't think that valve will stay for 7-8 years. It's going to come sooner. And explanting a Sabian valve in the presence of that calcium around it, I don't think it's going to be a big of an issue. Because that calcium it will protect your valve from adhering to the aortic wall and all of this.
I have one comment on the case. I think this case, in my opinion, should be done on the first day. You take it to the cath lab and try to do balloon as soon as possible to reverse all this biochemical degeneration, dearrangement that happens. I think it's all because this is a young guy, this is a congenital, most likely it's not coronary artery disease. So putting a balloon to relieve the obstruction will be the #1 priority.
Yeah, and I think that was a thought. No, that's a good
Because
point.
you waited 3 days, by that time his condition deteriorated.
Purposefully, for multiple reasons, this had a calcium score of 6,000. So the rate of AI, so you could make him worse.
Yeah.
So you could, so that was our concern. And he had no other reversible cause. He didn't have sepsis, he didn't have a GI bleed. So our feeling was he was getting better and not. In retrospect, of course, if we took him earlier, it would have been great. But that was the concept why we kind of thought he was heading in the right direction, then suddenly he didn't.
Great
In
results.
this case, if the surgeon will not take him, I will not be worried about doing balloon, putting any valve. It's just life-saving, so you have to act.
Great case, great results, great save, Dr. Mahmoud. Thank you very much. With that, we conclude this session. Thank you, dear panelists and co-moderator. Thank you very much. كل واحد جاي